I think one of the things that is hard, I suppose that I find distressing, is walking that line between giving hope. You've got to give them hope, otherwise it just can't continue. But also to be able to be truthful and not be disingenuous with the family. I find that hard.
I think there are good ways to communicate and there are bad ways, and you learn from both. And the journey is to observe and reflect on what's being done badly or not perfectly, and better ways to communicate, sensitive ways to communicate.
I think something that I've learned from families is that we may lose the child, but because of our actions and our support, we save the family. And I think that's very important to remember.
Hi, this is Connect, Pause and Reflect, CPR for clinicians. In this series, we hear from paediatric clinicians from across Australia who joined us as part of a 4-year research project to share their reflections on the experience of delivering care for complex patients. Our hope is that their shared reflections may help others to feel empowered, more connected, and able to appreciate how they make a difference to patients and families and what sustains them in the many challenges they face. In today's episode on the topic of grief and loss, clinicians reflect on some of the challenges around delivering bad news to patients and families. In the second part of this episode, clinicians reflect on the importance of modelling and including junior staff in difficult conversations. The final part of today's episode explores how clinicians navigate death and bereavement. Up first, clinicians reflect on the importance of honesty and the challenge of walking a line between giving hope and being truthful when delivering bad news.
I've always been of the opinion that because patients have access to the internet and to information, that it's far better to be honest than to deal with and support them having given them the prognosis. And it's interesting how some families will come back and say that was so valuable, we didn't like hearing it, but we were able to work with it. And other families will say, it was devastating what you said. I think that's part of what I've learned, why it's important that we do actually give open and honest opportunities for discussion about prognosis, about what expectations can be, but that we also realize that it's not always accepted by the family early on, and that we perhaps have to repeat it when opportunities arise.
There's not always a nurse in the room when bad news is given. It would be lovely if it was the gold standard, but it's not. So the nurse doesn't always hear that, particularly junior nurses. But what those junior nurses do is they're the people wandering around the bedside with all the jobs to do. So families often say things after meetings. You often observe across an 8 to 12 hour period the impact of that. You listen to them talking to relatives. You listen to share that with the medical team is really, really important. And that is essential. And I think as junior nurses and doctors and allied health as well, it's extremely important to share across the team how people perceive and observe how a family behaved afterwards. And I can think of many times when what the mother or the father repeated to me was very different to what the intent of the clinician was in that meeting. We cannot work in silos as clinicians. We must work in teams with these families, and we must all be on the same page so we don't create inconsistency.
I think one of the things that is hard, I suppose that I find distressing, is walking that line between giving hope. You've got to give them hope, otherwise it just can't continue. But also to be able to be truthful and not be disingenuous with the family. I find that hard. and communicating that in a really clear way that you know that they're going to understand.
I think you can get to being a consultant and actually never having given anyone any bad news. And so I have always thought it'd be better if they have some opportunity to do that in advance, particularly with you sitting there, so that they've got backup, but they actually are the ones to deliver the bad news. I think these days some of our juniors are very protected. There's consultants, fellows, and they never actually get to say something that's really difficult to a family, particularly if it's a life-altering, potentially lethal condition. That's something that they never actually get to do.
Next, clinicians emphasise the value of modelling and providing opportunities for junior staff to deliver bad news with supervision.
You know, I had the opportunity as an advanced trainee to deliver bad news, a terrible diagnosis with supervision, and recently had the experience supervising one of the trainees delivering a devastating diagnosis for which there was no treatment, taking her and just coaching her, getting her to practice the words that she was going to deliver, and then going to the room and, having the parents and delivering the news. She'll carry that with her like I carry my experience when I was an advanced trainee delivering that news, but just to include them in those. Because often you'd say, less people the better, let's leave the unnecessary people out. But actually the junior doctors to watch that is really good. And even to actually do it.
I certainly had one young, very great resident. Her registrar was on leave, the consultant was not around, and she said, "What do? I have to go and tell this family, this is really hard." So we did it. We planned it in advance. We planned how she was going to tackle it. We thought about in advance the different questions that she might get asked about, but then also about how she would feel about providing that news. And then she went and spoke to that family, and it was really well done. The family never asked me a question. All of the interactions with her, and she did a fantastic job. And she said to me since how that really made it much easier the next time she had to do it. She didn't have any backup, was that she'd actually had that experience, and she had a plan with how she could do it and also how she would cope with it afterwards.
In terms of fostering junior clinicians, I think there are good ways to communicate and there are bad ways, and you learn from both. And the journey is to observe and reflect on what's been done badly or not perfectly, and better ways to communicate, sensitive ways to communicate, taking time, listening, silence. All of those things are important for juniors to actually note those as it's happening and then to reflect on that afterwards.
I think it's really important to tell the juniors their language, the actual words and non-verbal cues, how they sit down on the bed, don't stand, all those things that, take the time, know that you're going to have a difficult discussion. Don't say 10 minutes, it's going to be 20 minutes. So you need to sit down, pull a chair up. You need to look at the mum and the dad or go about her. And you need to focus on them and be present, listen to them.
Openness. I have done quite a bit of grief communication this week, and the juniors have to see it all right from the beginning and be supported through the process, seeing how I deal with it, how they can share with me. Sometimes it's good, sometimes it's bad, but they just have to see how the whole system works and that they are an important part of that process.
Next, a clinician reflects on preparing for end of life once curative treatment has ended.
when we do have a situation where we advise the treatment is probably going to not be of value, or when we reach a point where we feel that everything has been tried, I think the important thing is to clarify for the family that we're not stopping care, even though we may be stopping treatment, and that in the phase beyond that decision point, we may be even more aggressive in terms of ensuring comfort, no pain, and support for the family. And I think that often gets lost in the media where on television they'll say, we're stopping care and it's almost go home with a packet of Panadol. And that's not how it works in reality.
Finally, clinicians reflect on the important lessons they've learned when navigating bereavement and death.
I think one of the things that I've learned, certainly from parents, is that they are very hurt when friends and family don't remember a birthday and don't talk about the child who is unwell or who may have been lost. And that's something that I always teach junior staff who say, what do I say when I see a bereaved family? It's very important to acknowledge that that child is always going to be part of their lives.
One particular family, after their child died, I was asked to come out to the waiting room because this mother was sitting in the waiting room. And the child had died probably 3 or 4 months before. And I knew her, and she just wanted to sit there. And so that perplexed me. But then it inspired me incredibly to think, you want to be here. And her reasoning was, I feel close to her here. As a junior clinician, I didn't realise that hospitals are a huge part of the world of these families, and they become familiar in a way that they don't for many, many other families who don't have sick children.
I think one of the things that I've learned over the years is that parents value coming back to see the people who knew their child, that in the bereaved period, the fact that they can talk to someone who can relate to what their child went through, what they went through, they find very valuable. And for that reason, we've often had parents coming back when our own reaction has been, surely it's very difficult to come into the space.
So when I was a very junior doctor, a first-year paediatric doctor, we had a really sad case where the professor was managing this case, and he was able to teach us many things, one of which was when he didn't feel like he did a good job, he took us aside and he said, I should have had you in the room to break bad news to this family so you could learn how I did that, but I didn't do a good job and I would do it differently. And then when this child unfortunately passed away, he said, I didn't see you at the funeral. And I said to him, I didn't think we would be allowed to attend. And he said, you always need to do what you think is right for you and what is right for the family in that instance. And from then on, I haven't gone to every child's funeral. And I always ask the family, what would you like? Would you like us to be there or would you not? And it's really important to be able to have that conversation with the family. But I think it was listening to someone who was a very senior professor saying, this is what I would do, and you need to make sure it's right for you so that you have closure about what's happened with that child, and you support the family and your colleagues if they happen to be there as well.
I've made a point of not going to funerals because there's no way that you can go to all the funerals. It's perhaps better not to go to the funeral. And I think although the families feel honoured and are very pleased when medical staff do attend. I mean, healthcare professionals that don't meet doctors necessarily. I think we can often play a more important role in contacting them sometime after the funeral and offering support or just speaking to them.
When I pick up on the going to funerals, I think it might be situational, but when I was in Newcastle, I went to the funeral of every one of my patients who died, and I guess I gave the eulogy in maybe a third of those cases. So clearly my presence there was important in a way that was very significant for the family. You've got to keep your act together. So it was a very frustrating thing as well as being a very rewarding thing, because you couldn't actually mourn at the funeral because you had to give the eulogy. When I came to Sydney, I didn't go to any funerals. In Newcastle, it seemed right. In Sydney, it seemed inappropriate. I know I can't explain to you why it seemed right and why it seemed inappropriate, but that's just the way it felt for me. So I don't think it's an absolute you should or you shouldn't go. I agree. You either go to them or you don't go to any. Newcastle's a smaller community, and not to go, I think, would have been just totally wrong. But others can feel differently. I mean, it's how you feel yourself that counts.
I think something that I've learned from families is that we may lose the child, but because of our actions and our support, we save the family. And I think that's very important to remember.
That concludes today's episode on delivering bad news and navigating bereavement. If you're interested in learning more about the research project behind these podcasts, or about hosting Connect, Pause and Reflect sessions in your workplace, further resources are available on the Sydney Children's Hospitals Network website. We would like to acknowledge the ClinEquip steering group led by Professor Annie Bai, including Fleur Leman, Professor Kenneth Nunn, Suzanne Nevin, Erin Beavis, Rachel McLaughlin, Rebecca McIntosh, Doctors Rani Sachdev and Elizabeth Palmer, and the ClinEquip Advisory Group who contributed to the co-design of these resources. We thank the Manildra Group for philanthropic funding. Thank you for listening.